Hello, can you hear me? Shall we begin?
Yes, sir. Yes, sir.
Okay. Uh, Hello, good evening, everyone. Let's begin today's session of the Journal Club conducted by the Neurocritical Care Society of India. At the outset, I'd like to thank the organizers for giving us this opportunity. So, we'd like to introduce today's speaker to you. Today's speaker is Dr. Niranjana. She's a junior consultant in the Department of Anesthesia and Critical Care at Hannah Joseph Hospital, Madurai. She'll be discussing on post-intracranial hemorrhage antithrombotic therapy in patients with atrial fibrillation. Over to you, Dr. Niranjana.
Yes, sir. Good evening, everyone. Thank you, sir. Thank you for the introduction. So, today I'm going to present an article on post intracranial hemorrhage antithrombotic therapy in patients with atrial fibrillation. This article was published in March 2022 in the Journal of American Heart Association, and this study was conducted by Shin E. Lin et al. Patients with atrial fibrillation have an increased risk of thromboembolism, particularly those with the charge to VAS score more than 2. So, coming to what is this charge to VAS score? It is a point based scoring system to stratify the risk of stroke in patients with atrial fibrillation. C, congestive heart failure, H for hypertension, and A, age more than 75 years, D for diabetes mellitus, and S, stroke. V is vascular events, and another A is age 65 to 74 years, and SC is the sex category. In this, age more than 75 years to be given 2 points, and the stroke has to be given 2 points. Score 0 is low risk for strokes, score 1 is medium risk, and score 2 is with high risk of stroke. The patients with charge to VAS score more than 2 uh, are usually recommended with the oral anticoagulants according to different guidelines. However, this oral anticoagulant increases the risk of bleeding. So, in after an episode of intracranial hemorrhage, OACs has to be discontinued immediately. Reinitiating this antithrombotics, either the antiplatelet agents or the oral anticoagulants, is after an episode of intracranial hemorrhage is difficult to decide, as it has to be decided based on the balancing the rebleeding and an occurrence of thromboembolism. This is the restart or stop antithrombotics randomized trial after an intracranial hemorrhage episode, which was conducted in 2019. According to the reports of this restart trial, reinitiating the antiplatelet agents when compared with no treatment after an episode of intracranial hemorrhage is associated with decreased risk of ischemic stroke and intracranial hemorrhage. But in this study, the study participants were only less than 20% of the study participants were with a history of atrial fibrillation. Another Danish study, which was conducted in 2015, which stated that reinitiating anticoagulant therapy after an intracranial hemorrhage in the patients with atrial fibrillation, when compared with no treatment, had significantly reduced the risk of stroke and all cause mortality. But contradicting to these two studies, a Taiwanese study which was conducted in 2016 stated that reinitiating oral anticoagulants after an episode of intracranial hemorrhage in patients with AF had significantly reduced the ischemic stroke, but had increased the risk of intracranial hemorrhage. So, several randomized study had proven that uh, non-vitamin K antagonists oral anticoagulants are equivalently effective to warfarin in preventing the risk of thromboembolism. But and also had significantly reduced the risk of intracranial hemorrhage. But the patients with the history of intracranial hemorrhage were universally excluded from many of the randomized trials. And in fact, warfarin is the most commonly evaluated drug, oral anticoagulant in the previous study. To date, there is less data on the effectiveness and safety of reinitiating the Novax after an ICH episode. So, the aim of this study was to investigate the effectiveness and safety of withholding or restarting the antithrombotic agents, either the antiplatelets or the anticoagulants, in patients with atrial fibrillation and intracranial hemorrhage. This study had also investigated different treatment strategies and compared them. Oral anticoagulants versus no treatment, antiplatelet therapy versus no treatment, oral anticoagulants versus antiplatelet therapy, and among the oral anticoagulants, which is better, either the non-vitamin K antagonist oral anticoagulants or the warfarin. This is a nationwide retrospective cohort study which was conducted in Taiwan during the period of January 1, 2011 to December 31, 2017. The population level data source of the Health and Welfare Database in Taiwan was used for this study. This data contained the information regarding the patients' enrollment, demographics, inpatient and outpatient services, diagnosis, prescription, and the cause of death. So they had enrolled patients who were more than 20 years who had intracranial hemorrhage, including intracerebral hemorrhage, subarachnoid hemorrhage, or any other intracranial hemorrhage, and patients who received at least one prescription of antithrombotic agent within 3 months before the ICH event. The antithrombotics were categorized as follows: non-vitamin K antagonist oral anticoagulant, which are dabigatran, apixaban, rivaroxaban, and eroxaban; warfarin; and antiplatelet agents like aspirin, clopidogrel, prasugrel, and ticagrelor. The patients were allocated into these different groups according to the exposure status. So, those who initiated oral anticoagulant agents were grouped into OAC users. Those who took antiplatelets were grouped into antiplatelet users, and those who did not take any antithrombotic agents were grouped into non-AT users. The effectiveness and safety in OAC users versus non-AT users, antiplatelet users versus non-AT users, OAC users versus antiplatelet users were compared. The index date was defined as 90 days from the hospital discharge after an intracranial hemorrhage event. For the comparison of Novak users versus warfarin users, the index date was defined as the first prescription of Novax, either the non-vitamin K antagonist or the warfarin after an ICH event. Despite the absence of Despite the absence of any current guidelines on reinitiating the antithrombotics after the intracranial hemorrhage for the optimal timings, this 90 days was chosen in the perspective that after the clinical observation that most of the patients would reinitiate antithrombotics within 3 months of discharge after the intracranial hemorrhage, and according to the recommendation that at least 1 month delay for post ICH anticoagulant therapy, as the risk of stroke is minimal when oral anticoagulants are initiated at 10 weeks. So the patients were excluded if they had valvular atrial fibrillation like mitral stenosis or any artificial heart valves, with structural brain disease like cerebral aneurysms or malformations of cerebral arteries, dissection of cerebral arteries, etc. Pregnancy, end-stage renal disease who required dialysis, those who had OACs and antiplatelets concurrently on the index date, and those who had intracranial hemorrhage or ischemic stroke during this 90-day period. Coming to the covariates, the data for the baseline characteristics and the concurrent medications were collected within the 6-month pre-index period. Information for the comorbidities were collected for congestive heart failure, hypertension, diabetes mellitus, coronary artery disease, myocardial infarction, peripheral arterial disease, ischemic stroke, transient ischemic attack, peripheral arterial occlusion disease, venous thromboembolism, pulmonary embolism, GI gastrointestinal bleeding or any other bleeding events, liver disease and renal disease, and information for concurrent medications were obtained for calcium channel blockers, renin-angiotensin system inhibitors, beta blockers, NSAIDs, digoxin, proton pump inhibitors, class 1 and class 3 antiarrhythmics. And the history of antithrombotic use was obtained for the 3 months period before the admission for intracranial hemorrhage. So coming to study outcomes, the primary outcome were ischemic stroke, intracranial hemorrhage, and all-cause mortality, and the secondary outcomes being major bleeding events and thromboembolic events. Statistical analysis. Inverse probability of treatment weighing was used to balance the baseline characteristics between the study groups. IPTW adjusted hazard ratios using the Cox proportional hazard model was used to evaluate the relationship between antithrombotic exposure and outcomes of interest. Statistical significance was defined as two-sided p-value less than 0.05. All the statistical procedures were performed using the SAS software. The study protocol was approved by the Research Ethics Committee B of the National Taiwan University Hospital. Written informed consent was not required because of the retrospective study. So this is the flowchart for the sample size selection. The study was conducted between January 1, 2011 to December 31st, 2017. So during this period, 5,007 patients were with atrial fibrillation who had subsequently developed intracranial hemorrhage. Among these 5,007 patients, 1,369 patients died before discharge and 22 patients were not discharged at all. So excluding these patients, 3,616 patients were discharged after an episode of intracranial hemorrhage. So for the analysis one, they had compared antiplatelet users versus non-AT users, or the OAC users versus non-AT users, and the index date was 90 days after the discharge. So in this group, 402 patients had ischemic stroke or ICH events between the discharge and the index date, and 339 patients had valvular atrial fibrillation, structural brain disease, dialysis, or concurrent use of anticoagulants and antiplatelet agents. 957 did not use antithrombotic agents at all before the intracranial hemorrhage episode, and 352 patients died during the 90-day period. So, excluding all these patients, 1,566 patients were the study participants, among of which 283 participants reinitiated OACs, 214 patients reinitiated antiplatelets, and 1,069 patients did not resume any antithrombotics. So for the analysis too, they had compared Novak users versus the warfarin users, for which the index date was defined as the first OAC prescription after the discharge. 1,899 patients restarted the anticoagulant agents. Among them, 220 patients had ischemic stroke or intracranial hemorrhage events between the discharge and the index date. 262 patients had valvular atrial fibrillation, structural brain disease, or went for dialysis, or they had concurrent use of anticoagulants and antiplatelet agents. And 343 patients did not use any antithrombotics before the ICH event. So, excluding all these patients, 1,074 were the study participants. Among them, 205 patients were the warfarin users, and 333 patients were the Novak users. So, coming to the results, the first comparison is between oral anticoagulants versus non-AT users. So 283 participants are the OAC users and 1069 did not reinitiate any drugs. zero point 0.7 years, that is 8.4 months, was the follow-up period for the OAC users, and 6 months was the follow-up period for non-AT users. Ischemic stroke occurred in 10 patients out of 283 among the OAC users, and 52 patients had ischemic stroke among the non-AT users with the hazard ratio of 0.61. ICH had occurred in 4 patients among 283 OAC users and in 17 patients out of 1069 patients in the non-AT users with a hazard ratio of 1.40. Thromboembolic events had occurred in 12 participants out of 283 in the OAC users and in 68 participants out of 1069 in the non-AT users with the hazard ratio of 0.6. The major bleeding events had occurred in 11 patients in the OAC users and in 42 patients out of 1069 in the non-AT users with a hazard ratio of 1.40. All-cause mortality in 48 users among the OAC users and in 235 users out of 1069 in the non-AT users. So the inference will be OAC users when compared with the non-AT, sorry, non-AT users had significantly lower risk of thromboembolic events, but had similar risk of major bleeding events and all-cause mortality. So next is the comparison of antiplatelet agents versus the non-antithrombotic users. 214 patients were the antiplatelet users and 1069 are the non-antithrombotic users. 10.8 months was the follow-up period for the antiplatelet users and 6 months for the non-antithrombotic users. 15 patients had an ischemic stroke episode in the antiplatelet users group and in 52 participants in the non-users group with the hazard ratio of 1.13. ICH occurred in 7 patients in the antiplatelet users out of 214 patients and in 17 patients in the non-users with the hazard ratio of 1.81. Thromboembolic events occurred in 18 patients in the antiplatelet users group and in 68 participants in the non-AT groups with a hazard ratio of 1.11. Major bleeding event had occurred in 11 participants out of 214 antiplatelet users and in 42 non-antithrombotic users out of 1069 with a hazard ratio of 1.10. All-cause mortality in 45 patients in the antiplatelet users and in 235 participants in the non-antithrombotic users. So, antiplatelet agents, when compared with no treatment, had similar risk of thromboembolic events and major rebleeding and all-cause mortality. So the next comparison is on OACs versus the antiplatelet agents. So out of 283 OAC users, 10 had an ischemic stroke event and 19 had an ischemic stroke event in the antiplatelet users group with the hazard ratio of 0.66. ICH had occurred in 4 patients out of 283 in the OAC users group and in 11 patients in the antiplatelet users group. With the hazard ratio of 0.40 and in thromboembolism had occurred in 12 participants in the OAC users and in 25 participants in the antiplatelet users with the hazard ratio of 0.54. Major bleeding events had occurred in 11 patients in the OAC groups and 19 patients in the antiplatelet users with a hazard ratio of 0.9. All-cause mortality occurred in 48 participants in the OAC group and in 76 participants in the non-platelet users. So OAC users, when compared with the antiplatelet agents, had significantly lower risk of thromboembolic events and the ICH event, with similar risk of major bleeding and all-cause mortality when compared with the antiplatelet agents. So next is between the Novax and the warfarin. Novak users were 333 users and 205 patients reinitiated warfarin. Uh, in the Novak users, 12 patients had the ischemic stroke, and in 9 patients for the warfarin users. ICH occurred in 5 patients out of 333 in the Novak users, and in 6 participants in the warfarin users with the hazard ratio of 0.5. Thromboembolism occurred in 13 patients in the Novak group and in 11 participants in the warfarin group with the hazard ratio of 0.8. Major bleeding event had occurred in 13 users in the Novak group and in 18 users among 205 warfarin users with the hazard ratio of 0.3. And the all-cause mortality occurred in 34 patients in the Novak users and in 39 patients in the warfarin users with the hazard ratio of 0.6. So, when compared to warfarin, Novak users had similar risk of thromboembolic events but had significantly lower risk of major bleeding, all-cause mortality. But no further comparisons were made between individual Novak agents and warfarin because of the less sample size. So, coming to the discussion, this study had evaluated the effectiveness and safety of different treatment options after an episode of intracranial hemorrhage event in a patient with atrial fibrillation. So, this study had suggested that reinitiating oral anticoagulants when compared with no treatment had significantly reduced the risk of ischemic stroke and did not increase the risk of intracranial hemorrhage. But when compared to antiplatelet agents, OACs had significantly reduced the risk of thromboembolic events and the ICH, intracranial hemorrhage. The effectiveness of Novax when compared with warfarin is similar in terms of ischemic stroke prevention, but the Novax had significantly reduced the risk of intracranial hemorrhage and they had improved the survival rate when compared to warfarin. But this study had shown that antiplatelets did not reduce the risk of ischemic stroke, but they had increased the risk of intracranial hemorrhage when compared with no treatment. So, ICH is one of the most common and serious adverse effects of oral anticoagulants. Physicians may be hesitant to reinitiate oral anticoagulants in patients with history of intracranial hemorrhage with atrial fibrillation, particularly in the Asian population, as the Asian population being the risk factor for recurrent intracranial hemorrhage. So, other risk factors being for the recurrent intracranial hemorrhage being age, blood pressure, extent of OAC exposure, presence of multiple cerebral microbleeds, hematoma size, and the location. So, the risk of rebleeding can be reduced by careful selection of the patient, controlling the reversible risk factors such as hypertension, and avoiding off label dosing of the oral anticoagulants. So, this study had stated that patients with a history of intracranial hemorrhage still benefit from reinitiating oral anticoagulants. So, therefore, it is rational to reinitiate anticoagulants after an episode of ICH in patients who are with very high risk of thromboembolism. When compared with warfarin, Novax had reduced the major bleeding events and they had improved the survival rate. So the antiplatelets can be used as an alternative treatment in patients those who cannot reinitiate the oral anticoagulants. According to the AHA and American Stroke Association guidelines, antiplatelet monotherapy may be considered in patients with a history of intracranial hemorrhage even and having the concern of bleeding. According to the report of Restart trial, antiplatelet agents did not increase the risk of recurrent ICH. They also significantly reduce the major vascular events like non-fatal myocardial infarction or non-fatal stroke when compared with no treatment. Although there is risk of all major occlusive vascular events is similar, but unlike the Restart trial, this study had showed antiplatelet agents had no benefit in preventing the ischemic stroke, and they increased the risk of intracranial hemorrhage, uh, which was consistent with the findings of Cao et al. And they had suggested the superior effects of oral anticoagulants when compared with the antiplatelet therapy. So the optimal time to reinitiate oral anticoagulants is unclear. According to 2015 guidelines of AHA-ASA on spontaneous ICH, they recommend reinitiating OACs at least 4 weeks after the onset of ICH in patients with no mechanical heart valves. This study had suggested the median time to start OACs approximately 6 weeks, which is even more conservative than the recommended guideline. But the data on patients with mechanical heart valves are lacking. A recent German study had shown that reinitiating warfarin in patients with atrial fibrillation within 2 weeks after the ICH had increased the risk of intracranial hemorrhage, and this has to be avoided. So, apart from the medical treatment, left atrial appendage occluder implantation is another alternative. According to the recent trial, which had shown the equal efficacy with Novax as for the bleeding in the higher risk of thromboembolic event patients. So the study had the following limitations. This is a retrospective study, so it is more potential for unmeasurable residual confounding bias. So IPTW was used to balance between the group differences. They had excluded participants who did not receive any antithrombotic agents before the occurrence of ICH, as they may tend to avoid the antithrombotic agents even after the episode of ICH. And this study was unable to determine the optimal time to reinitiate the antithrombotics post intracranial hemorrhage, owing to the retrospective aspect of the study. A randomized trial has a prospective randomization with the timing of reinitiating the antithrombotics is necessary to find out the optimal timing. And this study was conducted only in the Asian populations. So the results may not be generalizable to other ethnic groups. But this study had shown that OACs are the safe option in the Asian population, which itself is the risk factor for recurrent ICH. So OACs can be used in non-Asian populations also. And they did not check the CHATS2 score for the study enrollment. So, what are the clinical perspectives? Anticoagulant therapy reduces the risk of ischemic stroke without increasing the risk of recurrent intracranial hemorrhage when compared with no treatment. Antiplatelet agents is associated with a similar risk of ischemic stroke but increases the risk of intracranial hemorrhage when compared with no treatment. And non-vitamin K antagonist oral anticoagulants show similar effectiveness and safety when compared with warfarin, but they had lowered the mortality rates and they had decreased the risk of intracranial hemorrhage. Anticoagulant therapy is recommended over the antiplatelet therapy, and among the anticoagulants, non-vitamin K antagonist oral anticoagulant should be the priority of choice. So, on concluding, reinitiating oral anticoagulants after the occurrence of intracranial hemorrhage reduces the risk of ischemic stroke without affecting the risk of recurrent intracranial hemorrhage. Novax are recommended over warfarin owing to the benefit of survival and that they reduce the risk of intracranial hemorrhage. And the antiplatelet agents show no benefit in reducing the risk of ischemic stroke, and they had increased the risk of intracranial hemorrhage. So they may not be an appropriate treatment option. Thank you.
Thank you, Dr. Niranjana.
Yes, sir.
So it was a very good presentation,
Thank you,
and
sir.
I mean the conclusion is very clear as to what the study aimed to achieve. So before I go into the analysis of the study, just for the viewers, especially for the postgraduate students, so we discussed a journal today. So what is the importance of conducting such journal clubs in our uh, regular academics? We do seminars, we do case presentations. So what is the importance of doing such journal clubs? I mean, journal club is a platform wherein we come to know what is being done outside our domain or similar medical field, and it helps us to dissect a study, find out the limitations, find out the methodology, how they conducted a study, and same whether the same methodology can be applied to conduct a study here, and whether it is practically possible or not. And it also helps to develop critical appraisal skills. And uh, basically what we derive from the study also helps us to make important clinical decisions. Okay. Particularly this journal, Dr. Niranjan has clearly stated that the risk of hemorrhage is increased. Some of the risk factors that we have seen is the Asian race itself. So that itself forms a basis that to conduct research. That why is it more common in the Asian population? Is it to do with the cerebral vasculature? Is it to do because of prevalence of hypertension or any other factor that could have contributed to more risk of hemorrhage compared to the non-Asian population? So that's how you come uh, get an idea, fair idea as to what else can be done when we do a critical appraisal of a study. And this is especially useful for patients who are getting, students who are getting into research, postgraduate students or DM students who are willing to do research and incorporate that research findings into their practice. Yeah, I mean, as our teachers used to say, no research is useless. Even if it is a negative study, that also is useful, that you come to know that this is not useful or this is not practicable. So every study is equally important. When the methodology is correct, the analysis is correct, the statistical tests applied are useful, and that can be incorporated in our day-to-day practice. Uh, Now, I'd like to ask Dr. Niranjana.
Yes,
Uh,
sir.
so here in this study, they say that NOACs are safer compared to vitamin K antagonists, that is warfarin, it can be used in patients with an ICH history of ICH. So, what is the practice in your institute?
Said for patients with atrial fibrillation with ICH episode, immediately we stop the anticoagulants, and we will assess the risk of thromboembolism, so that we can know for how long we can stop the oral anticoagulants, and with the hematoma size and the location of the hematoma. So with that, we restart the anticoagulants or not.
Yeah, because in this study they have not given a definite time. They have
Given
just
the
said that
that, yes, sir.
yeah, they said reinitiating after 3 months, while
Yes,
the HA 2015 guidelines recommends that you can start it. I mean, minimum there should be a period of 4 weeks before an ICH event that you can initiate, or 4 to 6 weeks.
yes.
So that would like to know what is the practice in your institute, whether they
Usually
started after
four
6 weeks,
weeks, or
2 months, or 4 weeks. Yeah.
here we practice it with 4 weeks.
Okay. Yeah. So here also, I mean, I think here the neurologists are a little bit more conservative, so they give a period of at least 6 weeks before they restart the anticoagulants. And of course, we have seen a lot of cases. I mean, treated in the periphery who are on dual antiplatelets, and the risk of bleeding is definitely more with people who are on dual antiplatelets, especially patients with AF with a history of stroke and they've been prescribed dual antiplatelets. So a lot of them come with a history of present to us with an ICH. So in this regard, definitely, I would also like to comment that the NOACs are safer. Of course, you have to use them at the appropriate doses. Can you also elaborate on the NOACs, or more, some of the commonly used NOACs that we use?
Dabigatran,
Mhm.
rivaroxaban, apixaban.
Yeah, apixaban is one of the most commonly used NOACs. NOACs, earlier they were called as novel oral anticoagulants, but of course they've been in use for a long time. So they're no longer called as novel, but of course the synonym remains, it's NOAC. So it's non-vitamin K antagonist oral anticoagulants. And there's a lot of, I mean, in the recent times, a lot of resurgence and a lot of, I mean, usage of NOACs into our clinical practice. So yeah, of course, the patient selection is important, the right dosage is important, frequent follow-ups are important, control of blood pressure is again a very essential part, because as you said, the risk factors, among the risk factors, one is the Asian race, second thing is the number of bleeds, micro bleeds, size of the initial hematoma, and of course, the hypertension itself is a risk factor. If the patient's blood pressure is well controlled, then of course the risk of recurrent ICH also comes down. And so those things also have to be incorporated into the clinical practice. And if you feel that the patient who's non-compliant with his antihypertensive therapy, probably prescribing a high dose of a NOAC can be dangerous. So the patient has to be counseled, the patient's relatives have to be counseled before prescribing NOACs, that these are the risk factors. Patient can have a recurrent hemorrhage. So if it happens, how do you identify it? And you have to bring the patient immediately to the hospital. And yeah, so I think that sums up today's study. If there are any other questions we can take up, anything that you can see here. Yeah, there is a question for Dr. Niranjana. Did you come across similar study which is conducted as RCT?
That is RCT with for atrial fibrillation patients who are on oral anticoagulants going for post ICH is very less. But only with the patients with history of, I mean, like intracranial hemorrhage alone for oral anticoagulants who are for on some other indications, there are trials for that. But as such, the patients with the history of intracranial hemorrhage who are on oral anticoagulants for because of AF is very less.
I think that this is answer your question, Dr. Prabhu. Can you see any other questions in the chat box?
No, sir, I couldn't find out.
So at the end, can you summarize once again as to what is the practice and what is the recommendation and how do you incorporate into your daily practice and the findings from this study?
Yes, sir. So the reinitiating the oral anticoagulants is a safer choice, but among the oral anticoagulants, the vitamin K antagonist oral anticoagulants are the better than the warfarin, which but the
No,
warfarin is
it's
frequently used.
non-vitamin K antagonist. Vitamin K
Yes,
antagonist is
sorry,
warfarin. This is non-vitamin K
non-vitamin
antagonist.
K antagonist.
Yes, or the NOACs. Yes.
Yes, sir. Because they reduce the risk of thromboembolism and reduce the risk of recurrent intracranial hemorrhage, and they also improve the survival rates when compared with warfarin. And reinitiating antiplatelets, according to this study, it has shown no benefit, but there are some studies which showed that antiplatelet agents can also be reinitiated, but in this study, the antiplatelet agents had shown no benefit.
Yes,
Uh,
antiplatelet agents are definitely useful for ischemic stroke, but once there is a hemorrhage, with the use of dual, especially with dual antiplatelet agents, the risk of bleeding is much more. That has been seen. That's been seen in this study as well as other studies. So, in such patients, I
and,
think NOACs are a better option.
and there is another question I can see. Did they mention about dual or single antiplatelets in the APT group? There is no, they did not mention like that. It was just general anti. platelets. It was not mentioned as single or dual antiplatelet group.
Yeah, that's a very important question again raised because and what doses of the antiplatelet being used if it's both I mean aspirin and clopidogrel, or it's clopidogrel alone or ecosprin alone. I think it's safer to use ecosprin, but the combination of ecosprin and clopidogrel can be, or ticagrelor, or especially with ticagrelor the risk of bleeding is even much more. And yeah. Thank you for the questions. I think it makes the discussion even more interesting. So we would also appreciate if there are any more questions from the audience. Okay, if there are no more questions, then we'll sum up today's discussion. Thank you, Dr. Niranjana, for this wonderful
Thank you.
presentation. I could see the effort that you have put in preparing the slides, in going through the entire study in detail, also going through the other studies that they mentioned. Because, as I said in the beginning, journal club is when you do a critical appraisal, you go through the journal, also the studies that they have quoted, and that helps us to develop our research skills, also helps us to develop protocols based on what is being currently done, because the literature is rapidly revolving. Today you present a study, and next 2 years or 3 years this changes, so we have to keep ourselves abreast of the recent research, and this also helps in our clinical practice. Okay, thank you. At the end, I would also like to thank the organizers for the event, and especially Dr. Sindhu and Dr. Matangi for giving us this platform. I'm sure this will be beneficial to a lot of people who are using NOACs in their day-to-day practice, and especially the postgraduate students and the DM students doing DM in neuroanesthesiology or critical care to incorporate in their day-to-day practice. Thank you once again. So I think we can end the session now.
Yes. Thank you, sir. Thank you,
Thank you.
everyone.
Thank you. Thank you.